Good afternoon, everyone, and welcome to TEPI's Infection Prevention Module 209, titled Infection Prevention and Control Collaboration. This lecture is a brief overview that will introduce collaborative process that involves infection prevention and control areas across healthcare facilities. After we're done with the lecture today, then we will go into a learning activity and then open it up for question and answers after that. Before we start the learning activity, I'll pause and we'll allow everyone to answer and ask questions. We'll do our learning activity and then open it again for questions before we wrap the session. After the session completes, you'll see a QR code that will take you to a post-survey evaluation to kind of give us feedback specifically about the lecture. Within a week or so, you will receive a link to today's recording along with the slide deck. So the slides will be available usually within a week of the lecture, and they will be emailed and sent to you. Today's lecture is approved for 1 hour of continuing education for a certified public health if you hold your CPH or if you are a certified infection preventionist and hold a CIC. And there will be instructions at the end of today's presentation, just like previous presentations, to walk you through of how you obtain your certificate for your continuing education hours as well. So with that, let's get in today's lecture. So my name is Dr. Kayla Ruch. I am an infection prevention practitioner. I also have my PhD in epidemiology. I've been certified infection prevention for over 5 years. I've worked in acute care, long-term, and skilled nursing facilities all across the United States. Specifically in COVID, I worked in New York, Texas, and California before I came back to pursue my PhD in infection prevention, really focusing on education and training of infection prevention professionals and education. So I've come to work for TEPI, which is the Texas Epidemic Public Health Institute, which is housed at UT Houston School of Public Health in Houston. And the main mission of TEPI is to really keep Texans safe and our economy really strong by creating resiliency and increasing knowledge and education to help us better prepare for the next infectious disease outbreak. So at this point, it's not if another pandemic will happen, but when, making sure that we are prepared as a state. So with that brief overview, and at the end of the lecture, there will be some more QR codes and additional resources if you'd like to know more about TEPI in different courses that we have. Today's learning objectives for this specific lecture is to look at explaining infection prevention department collaborators, so who we work with within the IP department, describe and explain how we obtain stakeholder buy-in and support, and discuss different approaches, how we can get support from both the staff side and the patient side to make sure that we have that safe environment for patients and staff. So infection prevention collaborators. As I mentioned before, and as we've talked about in previous lectures, infection prevention and control has 3 main pillars for our for us. It's 1, to protect patients from transmitting infected agents. So we want to make sure that patients are not transmitting infectious organisms to other patients while they're in healthcare settings. And then we work at creating a safe work environment for healthcare staff. So making sure our healthcare staff and providers, everyone that's in the healthcare facility, feels comfortable, safe, and confident with handling infectious patients. And we try to do measures 1 and 2 in very cost-effective way of making sure that we're using good resources, we have good patient flow operationally and implementation-wise, that we are putting in effective suggestions, regulations, and practices to really ensure that we are staying safe, both as providers, practitioners, anyone in the healthcare setting, and then also for our patients safe. So we do a lot in creating a culture of safety for both patients and staff really requires a multidisciplinary approach both with different facets of controls, collaboration, protocols, procedures, resources, and throughout the departments and throughout the facilities. And kind of today, we're going to focus on different areas that we can collaborate and who can help us really achieve these missions of creating this safe environment for our patients and our staff. So one main thing, or one area that infection prevention and control can really gain collaboration and support to achieve these 3 pillars that we have, is our first big one is the Infection Prevention Committee. This is a committee that Infection Prevention and Control chairs and runs throughout the hospital. So it is a multidisciplinary committee that we specifically run. We set the agendas. We talk about our specific needs, both in our department, and we also align with our organization and system-wide need too. So if you're at a standalone facility or if you're within a big system, we'll talk about overall structural goals. And this committee then is developed as we chair to have second chairs and other representative individuals. We'll have the IC department, as I mentioned, that we chair it. We have our healthcare epidemiologists, which sometimes is within our department. Our medical directors, maybe that could be a infectious disease physician, a PhD, just depends, or an infection prevention practitioner. And then you start putting department leaders and administration leaders so that we are all in alignment and there's clear transparency of what is going on in our hospital and how we can all work to be safe in what we're doing and provide best care for patients. So this committee will advocate for infection prevention and control initiatives throughout the facility. We formulate and monitor patients' care. We look at policies, education, metrics throughout the facility or throughout the system. So this committee does a lot, and our main objective is to really ensure safety for our patients and our staff members. So this committee will meet regularly. It can be quarterly, it can be semi-annually, it can be annually, but you should have an agenda. You should be meeting and then kind of setting up goals and aims and objectives for the year. And that kind of goes into your risk assessment and your annual risk plan that we talked about in previous lectures. After you develop your risk plan, your committee is kind of your meeting to ensure that your plan is properly in place and that you are striving to achieve and you're on track for meeting those metrics and goals that you set within your plan. So if you have really scored something as high risk, then that in the Infection Prevention and Control Committee that you are frequently talking about, you're reviewing it, seeing if there's opportunities for process improvement, to ensure that there's no fallout, there's no patient harm events, or we're reducing the risk of patient harm events. And then we're also maintaining staff safety as well. So who should be in this meeting? So you want, since this meeting talks about all infection prevention and control practices, procedures, policies, protocols, throughput, resources, you want at least one leader from every department within your facility. And these are just to name some. And depending on your facility and what service lines in your facilities, you might have more people, you might have less people, depending on your specific needs. But definitely having a nursing leader, your CNO, your ACNO, your CMO, any one of your C-suite, if you can have a representative there to ensure alignment, or your unit directors, those would be some of your administration, your environmental service department, engineer, pharmacy, sterile processing, really all your high-risk areas, occupational health, your surgery department, quality, laboratory, respiratories, because a lot of times at these meetings, it is a touch base of making sure that, hey, what we're doing is safe, we're having effective treatment, and you really need everyone there at the discussion so that we can hear concerns or challenges or barriers that people are establishing or occurring, so that we can put in new efforts and kind of like relook at our policies, looking at our processes to see if there's any opportunity for improvement. So with those individuals there, we will talk about a bunch of infection prevention and control issues that go into our risk plan and our annual risk assessment, specifically our HAI rates, our healthcare acquired infection rates, our isolation compliance, hand hygiene compliance, high level disinfection, sterilization process. If there's any breaches in procedure, we'll talk about contamination rates for our blood cultures. We'll talk about antibiotic stewardship efforts, environmental care regulations, Joint Commission, CMS regulations. If your system has opt-in to leapfrog, you'll also discuss those metrics. Any types of multi-drug resistant pathogens that you're seeing within your community or with your specific community that your hospital or healthcare system serves, or overall in the county or in the state. This is also a great way to bring up hot topics that maybe a health alert network notification went out from the CDC, or if you're on a county or state infection prevention call with your local and state health department of bringing up concerning or potentially concerning issues at this time. You'll also talk about your occupational exposure events. Those will be any type of infectious exposure, your OSHA bloodborne pathogen exposure. All that information will be presented at this event too. Your construction project and then overall outbreaks and any facility breakdowns or procedure breakdowns, things that are learning events going forward that you would like to change and modify. So this committee talks about everything that you're doing for your annual plan, your assessment. So it's really important to get at least one representative from every department there to ensure that we are in alignment. There's clear and transparent discussion of what's going on so that we're all on the same page when we're really trying to create these initiatives for safety of our patients and for our healthcare providers. Another big committee that we talk about, and you'll reference it in the infection prevention committee, is your antimicrobial stewardship program, which was created from an executive order to really show at the emerging antibiotic use and the antibiotic resistance that we are starting to see and develop these MDROs and these more emerging pathogens. And these programs are really developed to help create your antibiograms, which we've talked about in previous lectures, really look at antibiotic usage, prescription usage, that we're making sure that we're giving the right dosage for the right bug to the right type of patient based on other risk factors as well. So it's a big collaborative effort to really ensure that we have great antibiotic stewardship and that we are only giving and using antibiotics appropriately. So this committee is usually chaired by pharmacy or your physician in charge of the other physician. So, and just here, one of the structures that the goals of these committees is to really have a leadership commitment of really showing or dedicating time of like, hey, this is a priority. We are tracking it. We're putting the expectation for all of our providers to be using antibiotics appropriately. You have accountability, which is usually chaired by a medical provider, an MD, to really talk with his or her other physician folks or prescribers of, hey, we are using antibiotics appropriately. Anytime that we have the opportunity to go from broad spectrum to narrow, we're doing that. Anytime that we can change from IV to PO, we are modifying as well, and that we're really using antibiotics appropriately. Then we have our drug expertise, which is led by our pharmacy team. Those are the ones developing our antibiogram and making sure like, hey, for this pathogen, we're prescribing this. This is the time and the dosage that should be gone for, or if we're having a certain type of procedure, it's actually this type of antibiotic prophylactically we should give for pre-op. And then our action is really looking at that we're reviewing our antibiotics, we're doing our timeout within 48 hours of getting to ensure, hey, if we started on a broad spectrum, are they really sensitive and where to that antibiotic? Should we be changing? Has our plan of care changed based on the information, how the patient has presented, how they continue to do in our facility? So then modifying and not just starting antibiotics and not reviewing cultures, reassessing of, hey, is antibiotics still appropriate at this time? Next, this committee also tracks a lot of antibiotics. Right now, the National Healthcare Safety Award, NHSN, which we report our healthcare associated infections, or HAIs, to, they also have an antibiotic tracking component right now that it is optional. And then depending on your type of specific facility, it might be mandated based on your system and county that you're in, of tracking and trending this, which there is discussion that this might become a requirement for CMS later of, hey, if you're wanting to obtain CMF funding and credentialing, that you will also be entering this antibiotic stewardship data. We do it with HAIs, we do it with our flu data and some of our other things, and this is the way that the pharmacy nationally is kind of going as well. We also look at reporting, specifically if we have a healthcare acquired infection, we'll look at what type of dosage was that used, specifically for surgical site workups, SSIs. There are specific pre-dosing for pre-operative procedures that patients should be getting, of making sure they're getting the right dose in the right route at the right time before cut, and that it has a protective occurrence, and that we're not just giving antibiotics and then we're starting the procedure within 5 minutes. We're giving enough time to actually have a protective loading dose effect as well. And then lastly, education, of just really educating our staff, all of our providers, all of our clinicians, everyone that's involved in patient care, of, hey, you know, there's a certain algorithm to testing and implementing antibiotics. We're working with lab, making sure the sensitivity for these cultures changing if it is resistant, that everyone's kind of working together and keeping an eye on this so that we're not overusing our antibiotics, which can lead to multi-drug resistance, and that we are not misusing them. So therefore, our patients, our length of stay, or LOS, in the hospital is longer because they weren't on the right antibiotic. For example, they get cultured and it's a gram positive versus gram negative, and the antibiotic is on for gram positive, and they actually have a gram negative bug. That antibiotic isn't going to be very effective, but it's going to start then creating a harder strain of that bacteria because it has been exposed to an antibiotic and then potentially absorbing some of its capabilities and creating plasmas, and then creating resistance that way. So we want to make sure that we're always reviewing our antibiotic stewardship. And as IPs, our responsibility when it comes to antibiotic stewardship is to first, in our action section, is when we are conducting our multidisciplinary rounds, that we are asking questions and we're looking at cultures. In the daily workflow of an infection preventionist, we are reviewing microbiology cultures daily, especially positive ones, and then we're looking at the resistance too. So also, when we are reviewing that, then we are confirming with the physician or pharmacy of, hey, the course of treatment, the new culture sensitivity came out. Is this antibiotic effective with the new sensitivity, or do we need to maybe modify our treatment change based that? And then we're also helping developing algorithms. We're working with IT to see if there's a way that we can build this. There's triggering to show that, hey, this is, they're prescribed a meropenem and this is meropenem resistant, that's alerting it. So we're kind of just driving and help supporting the conversation about antibiotic resistance. We're looking at this specifically when we go into our tracking phase. As I mentioned before, with healthcare associated infection, HAIs, we are specifically looking as there's a trend in a certain pathogen and resistance, because that might indicate that there might be a problem in your facility. If you have a certain persistent substrain of an MDRO, that might cause an environmental contamination. Maybe look at your water treatment plan, maybe look at construction, maybe look at your ORs or your high-risk areas, that if there's an environmental pathogen that's also MDRO or specific, very resistant or intermediate bug, that you want to maybe look at different cleaning, different process improvements. We assist the pharmacy team with any data that they need for their analysis, working with NHSN as well of making sure that we're all on the same page, they have access to, and then supporting them with the development of the antibiogram compliance, getting a copy, having conversations both in the antibiotic stewardship meeting and then also in the infection control committee meeting about these topics to ensure that, hey, everyone knows about it. We have our new antibiogram. It's been distributed. We're following it. There's no issues. Also talking about resources as well, like, hey, if there's a shortage, then they should be prescribing this, communicating that information as well. Then with reporting, communicating any discrepancies with internally with our team, and then also within our local and state health departments of the, hey, if we're seeing something specifically that is multi-drug resistant, letting them know right away, hey, we're starting to see this. Some main things, if we start seeing candida or drug resistant TB, those are great things that you should be alerting your healthcare, your local and state health departments about, of that, hey, we have this pathogen, it's really resistant. There's an increased risk to the community. And then tracking our HAI surveillance, as I mentioned. And then lastly, with our education, just kind of echoing what pharmacy and MD of everyone's doing with our providers, that, hey, we're using the right antibiotics. We know when to start. We know when to stop. We're asking if there's times that we can change from IV to PO. Is it safe? Which reduces the risk. And then we're on good antibiotic stewardship so that we don't have secondary infections such as C. diff, which is a big issue as well. So then other things that the next thing that we'll kind of talk about is with some of these culture of safety and infection prevention, how do we gain support within our facilities? So we have our two main big committees, our infection prevention committee that we chair, and then an antibiotic stewardship committee, which we support. Well, there's other things that we can do to really gain support. And we'll talk about kind of some behavioral health models that you can use to specifically change the behaviors and intentions within your facility to create a culture of safety, both on the patient side and on the health side, for reduction in healthcare associated infections, or HAIs, for good antibiotic stewardships, to reduce MDROs, which are multi-resistant organisms. So today we'll kind of just briefly talk about 4 health models that you can use and go through some examples of how to really change behaviors within your facilities. And these health models can be used in different ways based on your specific behaviors and culture that you've developed within your facility. So it might, when you're looking at it, you might pick a different model based on the certain person, if it's a staff or a healthcare worker, the culture, or the department. So the first behavioral health model that we're going to look at is the health belief model, which was developed in 1990s. And it's really driven to look at the rationale of an individual, of how a person determines their behavior based on objective and logical thought process. So kind of understanding how they develop this behavior based on how they are logically understanding the situation. So going into your thought process, you have your core development, which is your demographic information, and also like your psychological characteristics. So you as a person goes into specifically kind of what your thoughts and feelings are, and then you go into different subcomponents as you see here. So the first one is your perceived susceptibility. So the individual look at how they will be potentially affected by the type of behavior that you're trying to look at. So they're looking at, how the likelihood of developing this type of issue or causing harm. So that's your first thing. And then your next thing that they look at is the severity. How severe is this situation? Is it, if I don't do this, is it going to lead to death? Or if I don't do this, is it going to just lead to a bad outcome? So then looking at the severity. The higher severity that something might be doing, or such as a behavior, the lower cue action you'll have to develop with that. So if someone already thinks, hey, I need to do this, otherwise, this could cause harm to my patient, or as a patient, I might get more sick, you're going to need a lower cue to action because the higher perceived severity kind of makes it more important. And then you have your perceived benefits of the individual understanding why this is beneficial to do. How is it protective? How is it helpful? Or on the other side, how does it reduce harm to the patient or to myself? How does it protect me? And then the next one is your perceived barriers. What are your obstacles to kind of look at this thing? Is it physical? Is it internal? Is it external? Internal is it something that maybe I don't understand why, and therefore I'm not willing to do the activity? Or is it something external that, there's an external barrier, such as if you're trying to create improved hand hygiene, you do not have hand hygiene or dispensers throughout your facility, or you don't have any alcohol, so you can't have people do hand hygiene, and all of those different components. And then lastly is your self efficacy, and that's how you feel confident doing the behavior. If you are more confident, you feel like, yes, I can do this, they're more likely to be compliant and do the behavior, which will lead to action to the specific behavior that you're looking at. And then depending on how severe in the susceptibility and the benefits and the behaviors, then you'll look at cues to action of how to then drive a certain behavior. And we'll give kind of some examples to look at this model next. So an easy behavior that I thought of to specifically talk through this model was hand hygiene. Hand hygiene is always a challenge, both on the staff side and on the patient side. And we'll first talk about the patient side. How can we get our patients to really wash their hands when they're in the hospital system or healthcare facility? If you're in an outpatient clinic, if you're in an LTAC, if you're in a skilled nursing home, how can we get our patients to wash their hands? Because that's always a challenge. So we want to make sure that you're taking into account their background and their knowledge on hand hygiene. So knowing if it's important and are a top priority for them. Then you're going into their perceived susceptibility of like how important do you think that patients know that, hey, they're susceptible to get an infection, so therefore a preventative thing I can do is clean my hands. So really not just assuming that patients know that, hey, we have tons of little bugs on our hands, so we want to make sure that we're washing our hands periodically, that then you're also communicating that and you're kind of driving those cue to actions of, doing by example as staff members, washing their hands, promoting hand washing, talking about hand hygiene. You're also seeing different graphics within the facility about hand hygiene. I know we talk about it a lot, but there's really nothing over the top. You can't have too many signs, can't be talking about hand hygiene enough. And then the severity. So talking about how severe it can be not to wash their hands, that it is really important, especially when we're in the hospital, we're immune compromised, and the easiest way to protect ourselves and our patients is hand hygiene. So definitely echoing that message and having that specific messaging of saying, hey, and a thing that you can be a part of your care is wash your hands, and definitely engaging the patient and letting them know something that they can do and kind of take more control and being part of actively in their care and preventing additional infections, longer hospitalization, is then hand hygiene. So then looking at the perceived barriers of, hey, if they're bedbound, then do you have hand hygiene around on their overtop table? Is there hand sanitizer? Is it filled? Promoting that their sink in their bathroom is working. If it's not, letting facilities know that they can come in and fix it. And then also like talking about their self-efficacy, like promoting, being confident, really positive reinforcement of, hey, you can do this, hey, be a part of your care, by washing your hands, you're really protecting yourself and you're actively participating in your treatment plan. And then kind of mirroring those cue actions of talking about it, demonstrating, leading by examples, having hand hygiene available for your patients, and then also having signing within your facility. And then the same thing goes with the staff. So you want to take a different approach, but kind of turn the script a little bit more of, hey, really to reduce harm to your patients, the number one thing that you should first do is hand hygiene. It has been statistically shown if you wash your hands, that is the first step of preventing healthcare acquired infections. And our patients are immune compromised. We're really making sure that they are safe here. So talking about how hand hygiene is the best way to prevent healthcare acquired infections. We don't want to induce harm, which can lead to longer length of stay or potentially mortality, so that we're not accidentally putting indirect harm on our patients by having dirty hands because we forgot to wash our hands, and really echoing that and putting cues of action, making sure that everyone is washing their hands, reminder of washing their hands, promoting hand hygiene, talking about it at huddles, talking about it at meetings, sharing your hand hygiene data within your facility, and then really just being kind of transparent with your metrics, and then really just being confident, telling everyone positive reinforcement at your facility. You can also look at incentives for hand hygiene, doing, points or shout out, doing different raffles. You can get creative with that, giving out hand hygiene, little alcohol, hand hygiene things the individual wants. That's a great incentive to really kind of change that behavior of hand hygiene is the number one thing that we can do to stay ourselves as providers stay safe and to reduce harm to our patients. And then here's another way, just kind of reframing the script, to really talk about HAIs, that hand hygiene is the first step of eliminating HAIs, how HAIs can lead to mortality for our patients, and we really need to drive hand hygiene compliance. So the next type of behavioral theory that we can look at is our planned behavior, which really looks at as a psychological model that explains attitudes, social norms, and perceived control that really influences our intentions and our behaviors. And this model kind of looks at, as you see, that these main things, the attitude, subjective norms, and perceived behavior control, leads to our intentions, which drives our behavior. So these components, such as attitudes, which can be positive or negative on a certain thing. If it's positive, then you'll have a positive intention that will drive that behavior. But if our attitude is negative towards a thing, we might not have the best intentions because we have personal bias or negativity on the thing. We don't think it's that important. We don't think it's going to work. And that really will show lower intention of actually being compliant with that behavior, which then will least likely show the behavior that you're trying to do. You can look at your subjective norms, which every individual has, which is looking at your social pressure to perform a specific behavior or not perform. So what is your colleagues doing? What is the organization? What's the expectation? So that's kind of looking at those things specifically within your organization of how you can drive to change your attitude from a provider and patient's perspective towards positive. That will then increase your intentions, which drive the behavior that you're trying to address. And then lastly, looking at perceived controls, which is your perception, the individual perception of the ability to perform the behavior. So looking at what types of obstacles are there within. Is there any type of internal, external obstacles? Can they physically drive the behavior that you're wanting to do? Do you have the resources? Do you have the policy or procedure that you're trying to change that really is going to drive the intention that's going to change the behavior and create this atmosphere of safety, both for patients and providers within the system? So some examples that you can use this is really looking at PPE compliance. I know we're going into flu season, and definitely you can use this type of model with flu vaccination, with masking, depending on your county and state regulation of how we are going to handle flu. It's always in a changing world since COVID-19. So specifically looking at our attitude towards the behavior. So what is our attitude towards our specific behavior of PPE compliance? Are we talking about it? Have we educated? Is there positive? Do patients know why they should be wearing PPE? So first on the patient side, when we're trying to get them to use PPE, do they understand the why, how it's protecting them, and kind of their attitude towards like, hey, this is something that we need to do. It protects you. It also protects if you're visiting someone that's immune compromised. It's a layer of protection that you're not accidentally causing indirect harm or unintentional harm to them. And then you're looking at their subjective norms. What are their thoughts and feelings on PPE compliance? And do they understand that it's a safety measure? So definitely really echoing that when you're talking about safety with patients. And then you're also looking at their perceived control. They know how to do it. They know how to don and off appropriately. They feel comfortable. They feel confident doing that. Specifically, if you're putting on a gown or putting on a mask, they know how to, for your surgical mask, scrunch around your nose and that it should cover this area. It shouldn't be down here. It shouldn't be down here. It should be on the side or the side. It should be in your specific area and it's fit appropriately. Taking a moment to have those conversations with your patients and with their visitors of why this is important. This is how you need to do. Which is really going to show that they're understanding their intention. Therefore, they're more likely to be compliant with PPE. They know how to wear it. They know when to wear it. They know not when to wear it, as in if they're leaving a patient room, they are taking off their gown. They know how to don and doff properly, or they're asking questions, and that you've created that positive environment where they can speak up and ask you questions as providers there to know how to do things safely, and that will really drive their compliance in healthcare settings of using PPE. And same thing goes with staff. Staff understand the importance of it and the severity of, hey, we need to wear gowns in isolation rooms because that whole environment is contaminated and we don't want to accidentally put a microbe on our clothing and then take it into the next patient, or we don't want to take it home or out into the community too. And why PPE is not only used for our patients' protection, but it's us. It's every individual has natural bacteria on their skin. We have our skin common commensals that are healthy bacteria, but if I'm immune compromised, my healthy bacteria that I have on my day-to-day might be harmful to someone that doesn't have that strain of bacteria. Me, I'm not affected, but they are. So having that conversation, you can use that both with staff, and then you can use that with patients as well too, of making sure that they understand that for staff with PPE compliance, you can always put in that it's a safety, it's an OSHA requirement, it is a Joint Commission requirement, it's a CMS. So not only for our safety, but as providers, we are obligated to wear this for the standards. It's also CDC puts in certain standards as healthcare providers that we need to do. And then looking at perceived control, can they don and doff? Do they know how to put their PPE on without cross-contaminating? Are they following good hand hygiene practices? Before and after that they're taking on and off their PPE for things, and you can do that with other components too. You can also do that with toolkits, that any type of new initiatives that you're starting to look at. For this specific example shown on the screen, you can do a new surgical toolkit that is a bundle trying to reduce surgical site infections, of making sure that your pre-op, intra-op, and post-op are done appropriately. So your surgical team knows about the toolkit, you're positively promoting it. It is an expectation. It's because we've had HAI's development or best practices show from CDC, SHEA, APIC, IDSA that this is a great preventive toolkit that you're using. You're having set up that you have resources to do it. If you're having a certain type of material If you're doing a certain type of drink beforehand, if you're giving them the CHG bathing and prep, that they know how to do that, that's in stock, so that there's not any barriers that they can physically carry out the toolkit. It's been rolled out, they've been educated, they know about it. That will really help drive intentions, which will then drive behaviors of using the toolkit to prevent HAI reduction. Our next theory is looking at social cognitive theory, which is our cognitive factors, our environmental factors, and behavioral factors that go into our decision-making process. And it really explains human behaviors in terms of looking at these three main categories and kind of looking at them specifically for good infection prevention practices. The main premise of this is that we learn a lot by observing and which our practices. So it's developing that culture and we're learning by example. So we're looking at our colleagues to lead by example for these specific behaviors. And within the social cognitive theory, there are many components specifically, as you see here, but the major ones that really they look at within this one is looking at the observational learning and looking at really learning by example. So this is, you have to lead by example. As infection prevention practitioners and leaders in the hospital, we have to be the first front line of, hey, this is what we need to do all the time. They observe us all the time. So we need to make sure that we are staying up to date with practices. We're leading by examples. We're always demonstrating compliance, because the worst thing that we can hear is that, hey, we're echoing safety, and when we're not leading by example, it kind of puts a lot of your efforts on the lower end, because they'll look at it as, hey, you're not driving it, you're not acting or showing that we need to be doing these certain things. Maybe there's less validity into, therefore I don't need to be doing that. And a great way to do this is to get champions within every department or every unit to have a infection prevention champion kind of look at different things that you can implement, so that they can see at their specific unit level, like, hey, this is best practice, this is what I should be doing, this is how I should be doing that, that's how I should be approaching this problem. So some ways that we can use this is specifically on the patient side. This one just talks about overall health and nutrition. Definitely, it kind of goes out of the infection prevention component, but if we have healthy patients, they're more immunocompetent and they're less likely to have an infectious or chronic disease. So always making sure that we are talking about nutrition, daily exercise, vaccination, kind of living that healthy lifestyle and kind of incorporating that One Health model of, hey, everything plays into component with each other, of making sure that we have a well-rounded individual and providing health to them, not just in the infection prevention space, but in other healthcare spaces too. It kind of all feeds into it, because if they have poor nutrition, which then they're diabetic, then it leads to increased ulcers, which then increase risk of wound development, abscesses, amputations, secondary infections, increased use of antibiotics. It kind of all flows into together. So just kind of looking at different ways to incorporate social learning, looking at your self-efficacy of how well that you can demonstrate this behavior, looking at specific outcomes, expectations of doing this will drive this type of outcome, and really messaging that to individuals. And ways that you can apply this is developing education programs, support group, individual care plans, patient education, and follow-up and feedback are top ways that you can really address these things of making sure that patients educated on best practices, they're in support groups, or they can talk to other individuals, maybe with the same or similar workup or situation, so that they can get more support, they can get understanding, not just as a clinician or healthcare perspective to that patient, but you can also have that conversation for patient to patient, individually, and of tailoring things to their specific plans of what they can do, and then educating them as well of, hey, this is best practice. This will reduce your risk. What you're doing is potentially causing harm to yourself, and then following up with them and kind of closing that feedback loop. So having clear, consistent, transparent conversation. And with staff, you can use the same thing too. Definitely creating that culture of safety by leading by example, demonstrating, talking about, answering questions, looking at reinforcement, incentives, looking at behavioral capability of, can they do that? Do we have the resources? Are we promoting it? Is there signage? To really looking at certain ways to really show that, hey, this is important. This is what we're doing. This is what our institution is really driving for patient and staff safety by this certain types of initiatives. So definitely talking about the how. And same thing, same, but almost slightly different than on the patient or on the staff side of looking at mentorship programs. So having a more seasoned individuals with a newer healthcare provider of showing them best practice, kind of explaining and understanding, especially in infection prevention and control. We use a lot of the train-the-trainer model. So if you have an experienced IP within your system that you're partnering with them, you're asking them, also just kind of getting their experience and buy-in of what are additional things that we can do to really help drive infection control practices within our facility, simulation trainings such as this, and going through different skill sets, rounding, observing, feedback mechanisms. So not only doing trainings with groups, walking on the unit, observing, doing audits, as well, and then also being understanding of cultural and environmental considerations too. Sometimes in infection prevention, we kind of get siloed in our perfect box of, oh, this is great, we really want to do this, but we also need to then kind of confirm culturally, is this appropriate here in our facility? And then also environmental considerations. Do we have the capacity to do this on a staffing side, equipment side, a throughput operation side too of what we want to implement? Because as we've seen in some cases that we can have a great thing on paper, but then when you actually go to implement it in practice, you need to modify it because that maybe isn't your flow. Maybe there's a staffing, there's a equipment shortages. You need to have that multidisciplinary approach. So definitely talking about these initiatives, going back to the infection prevention committee to have all the leaders there so that they know, hey, this is going to work or not going to work, and that you're openly talking about it. And then the last module, behavioral health module that you can use is called the COM-B theory, which is your capability, opportunity, and motivation behavior. And it's kind of a newer model. It's the newest one that was developed in the late 2000s, kind of looking at different components that we've already talked about, of looking at their individual psychological and physical capability to perform the opportunity to perform the task, looking at the actual opportunity. They have the opportunity for doing the task, and then it's a motivation behavior. It's fostering a sense of responsibility, so internally and externally reflective on that certain behavior. And this is one I'll leave for your reference, but just our C. diff isolation compliance, looking at, their understanding the why behind their on isolation. They need to use soap and water, why they shouldn't be sharing bathrooms, to really reduce the risk of exposure to other patients with C. diff, and kind of looking at different motivational factors for them to really help implement on the patient side. And then lastly, looking at different isolation measures for C. diff patients on the staff side. So different things that we can talk about our staff about: screening appropriately, isolating, making sure that we're using the right products, that, to ensure that they're cleaning appropriately. Do we have a bleach-based product with it on the unit, and are they educated to use it? Do they have the opportunity to use it, that it's there, they know how to use it based on that product, they're using the appropriate wet time, or is that product out of stock and we don't have it and therefore we're not using it? So all of these different things that when you're thinking about product improvement and you're doing a KPI or a quality improvement project, you're looking at these behavioral health models of kind of driving that implement change. I know behavior change is really challenging to do, and it takes a long time to implement something, and it's really takes a long time and a lot of effort, multidisciplinary, to have it develop a culture. The last thing that we kind of talk about is really knowing the why, what, and how change benefit. That is always a strong driver of behavioral change when you're looking at infection prevention collaboration, and people understanding why they need to do things a certain way, what they need to do, how they need to do it, what they need to change, and why is it beneficial or it's reducing harm. And then lastly, and if that doesn't work, using data to talk, as we've kind of talked about in other modules this year about data handling, looking at surveillance, data presenting. Data always talks very loudly, especially to your C-suite, of trying to look at things. So tracking your compliance and knowing and understanding your data, you can really see that there's an opportunity or we need a cultural change on behavior, such as if you have low hand hygiene rates in your facility, then kind of going and looking at the hand hygiene behavior and then seeing what type of model you can implement to try to change the thoughts and feelings on hand hygiene to increase your compliance. So some big strategies, I'll leave these for your guys' reference, but looking at education, leadership, and modeling and communication, as I've already talked about, including behavioral incentives, reinforcement, multidisciplinary collaboration, as I've mentioned previously, environmental and system supports, and then addressing cultural and behavioral barriers, both on the patient side and then same on the staff side, of making sure that you have good education campaigns and trainings. You are leading by example. You have leader buy-in and support, and they're leading by example. You're creating IPC champions within units and departments. You have clear, consistent communication and feedback. You're getting input of what IPC practices you want to implement, and actually, if it's feasible, from resource flow and just overall systems-wide feedback. You're looking at behavioral incentives and reinforcement. So any giving out points, rewards, incentives, making it fun, making IPC fun, giving out different fun, like little bugs, like stuffies, plushies, or stickers, or candy, or anytime that you can really put in incentives that will really help drive positive behaviors and a positive association on that behavior. Multidisciplinary collaboration, environmental and system support, that you can physically do what you're wanting to do, and then you also have the support within the structure, organizational structure to do, and then lastly, always addressing cultural and behavioral patterns too. Is this the right time? Is this the right behavior based on our culture within our facility, within our organization, within our community, and within our county and state to be doing this to show success? So kind of keeping all of that in the mind when you are developing programs and trying to really change behaviors. So now we're just going to quickly do our learning check, and then I know we're a little short on time, so I'll have you guys scan the QR code, and then I will answer all questions at the end after the learning activity. So you can all scan the QR code. We'll quickly go into the learning activity, and I encourage, at this point, we want it to be interactive. You can definitely put your answers in the chat to show that you know what you think, and at the end, if there's any questions, we'll definitely answer those. And so it's a quick, just a 10-minute learning activity. Okay. All right. Question 1, what are the pillars of infection prevention and control? Is it A, is it B, is it C, or is it D? Great. Yes, it is D. Excellent. 2, which departments does infection prevention collaborate? Is it nursing, environmental, micro, or all the departments? Yes, again, all the departments. Infection prevention touches every single department within your facility and is every single person, both staff and patients' responsibility to create a culture of safety. 3, what committees help drive IPC practices? It's the IP committee, and what other main committee did we talk about today? Is it the nursing stewardship, antimicrobial stewardship, medicine stewardship, or employee stewardship? It is B. We talked about the infection prevention committee and the antimicrobial stewardship as main drivers of IPC practices. Question 4. In the health belief module, what is the goal, or what does it lead to at the end? What are we driving towards? What are we using our susceptibility, severity, self-efficacy, barriers, and perceived benefits to? What are we looking to try to lead to? It's C, action. Yes, that is correct. 5, in the theory of planned behaviors, what do the intentions lead to? So you have your attitudes, your subjective norms, and your perceived behavior control, which lead to your intentions, which drive what? Your behaviors, your ideas, actions, or motivation. Yes, it's A, behaviors. Question 6, what factors in the social cognitive theory are involved in comprehending the complex interaction of environmental factors, human interactions, and what? Is it A, coping mechanisms, B, cognitive factors, C, cognitive thought through processing, or is it D, cognitive development? Yes, it's B, cognitive factors. Question 7, what does the C stand for in the COM-B theory? Is it culture, capability, creativity, or collaboration? Yes. B, capability. Question 8, what is a social cognitive theory application? Is it our mentorship programs and simultaneous learning, positive feedback, environmental consideration, cultural consideration? Option C, both A and B. D, lead by example and positive reinforcement. Yes, it's C, both option A and B. Question 9, what methods are effective in compliance with patients and staff? Is it an education campaign, multidisciplinary collaboration, C, addressing cultural and behavioral barriers, or D, all methods are effective? Yes, D, all methods are effective. And our last one, true or false, change in compliance for infection control can be can leave behind the why. Yes, it's A. And then here are your answers. And as I mentioned before, within a week or two, you will have receive an email with today's recording of today's lecture, along with a slide deck for you to be able to reference later. So we talked about a lot of different things today about driving infection prevention control practices. And the main takeaway I want you to really understand is that it takes a lot to develop a behavior towards infection prevention practices. These are just a few behavioral health models that you can use to try to drive a cultural change within your facility. But definitely explaining the why of importance will really be very beneficial for you to driving change. And it's everyone's responsibility to really produce an environment of safety and to really show those infection prevention pillars of safety for our patients, safety for our providers, while we're doing it in a cost-effective manner. So lastly, I'll have everyone invited to connect with us. Here is our contact information. You can reach out to us with specific questions, anything that was unclear. We're more than happy to discuss with you. And then our next module will be in a month, and we'll talk about quality improvement. We're specifically going to talk about a case study of how to set up a quality improvement projects, looking at healthcare acquired infections, specifically with CAUTI, urinary tract infections, prevention of kind of how you can do, what things you can do to try to drive the bar to reduce your SEER rate in your number of catheter associated infections. Here's a QR code for our post-survey evaluation. We really appreciate all your feedback. For the material, it helps us really develop these modules specifically on content that you would like to see that maybe you're struggling with, provide you resources. It's all a great way kind of to see going forward of how we can help you. And now with that, I would like to open it up for any questions. And then as I mentioned before, lastly, today's lecture is eligible for 1 hour of continuing education for certified public health professionals and CIC. You can go to your dashboard, and then there is additional slides at the end of the deck that you will receive, again, within a week, just show you step-by-step of how to complete the things that you need to obtain your certificate to show your 1 hour of continuing education. And with that, now I open it up for all questions.
There is one question saying, how hard is it to change behaviors of populations with low health literacy and poor income groups in the U.S., specifically in the state of Texas?
So that's an excellent question. I mean, that's a very broad question. It kind of goes into your specific facility, your culture, your community. If you're wanting at the population level, not within specifically your facility, you can partner with your public health, your local county public health, to try to get alignment in really reducing misinformation about public healthcare, and kind of making sure that your messaging is really effective on your literacy within your population too. So if you're needing to rechange it, in one of the modules previously, we talked about communication. So making sure that you are modifying your communication through your different audiences. So depending on one group of people that you'll be working with, one service line, or the general public versus another service line or a different group within the public, you will change your messaging. Not necessarily the impact of your message, but how you are saying that based on their literacy, their education background, and their personal beliefs on it too. So definitely taking that into consideration. We're always here to drive best practices and kind of just communicate to everyone that, you know, we're here to help. We want to provide best care for our patients in a safe way. And then also on the provider's side, making them feel comfortable providing care based on best practices. But excellent, very tough question.
Continuing to that question, they ask, what can be done to change the behavior of newcomers and DACA populations?
So newcomers, definitely meeting with them with hospital or healthcare or facility orientation. I try to go for new employee orientation to kind of set the tone of expectations, what our culture of safety is here, who you are, what resources you provide, just kind of being visible, talking with people, being patient, hearing them out, going into conversations with an open mind, understanding their perspective, active listening to them can really, really help increase their compliance with those things and kind of also increase their understanding, which the more they understand, they'll have better intentions and then drive the behavior that you're wanting to change. But excellent question.
What specific patient-oriented intervention campaign to reduce nosocomial infections has been most beneficial?
I think it really depends within your specific community and what types of pathogens. So everyone's pathogens, if they have a lot of common commensals and what specific common commensal that you have within your specific organization is based on your community. If there's a lot of things, your water, soil, and air, you'll see different pathogens on the skin versus another demographic. It kind of based on your initiatives should be based on your pathogen. So like if you're specifically seeing a Pseudomonas, an Enterobacter, if it's more, staph, if you're seeing a Candida, not Candida auris, but other just Candida normal yeast. So first look at the specific pathogen and then look at resources to way to reduce that pathogen and then develop your intervention that way. So try to look at the specific thing because different approaches will be based on different pathogens, and then you can also tailor it what specific service line or what type of community that you're having to kind of address it. Like, is it a pathogen that you're seeing in agricultural workers, dairy farms? Is it something that you're seeing within healthcare industry? Is it service industry? Is it hospital? Is it mining? Is it oil and gas? So you're looking at the pathogen and then the specific community or type of service line that it's affecting. And then with those two main things, then tailoring your intervention behavior. Another great question.
And lastly, someone is just asking, how do they access this dashboard?
The dashboard, the slides will be sent out within a week or two, along with the recording of today's lecture for you to have access to that. If you're wanting to look at your antibiogram within your facility, talking with pharmacy to see what pathogens that you're commonly seeing in your patients, they will have that information. So just asking pharmacy. You can also ask your microbiology department of what if they're trending different pathogens within the community. Another access is that, or another resource would be asking your county's local public health department too, of seeing what is within your facility and in your environment in your county. That's another thing to kind of see what's going on in your area.
Those were all the questions.
Great. Well, we thank you all for attending today's lecture. Please reach out to us if you have any questions. And we look forward to seeing you next month at our quality improvement lecture. And was there any more questions? Thought I saw someone's hand raised.
Nope. Someone just said that they would like to participate in future sessions and also get the certificate.
So if you reach out to us to get when you get access to the slide deck, it will take you step by step on how to get the certificate to go forward. But yes, please, within the slide deck, our email's there. Please reach out to us. We're always looking to collaborate as well. So thank you all for a wonderful lecture, and I look forward to seeing you next month. Thank you.